As we have learned in the previous sections, interpreting radiographs is a much more complex process than we might first consider. We must account for the processes our eyes and brain use to reconstruct images in our mind's eye. False reconstructions can be identified and compensated for if you are aware of them and train your eyes and brain appropriately. You must also account for the fact that our eyes have a limited area of acute vision, and we must be very thorough in looking at every area of an image. Remember, your brain always fills in the missing pieces by reconstructing an image based on prior experiences. And finally, you must learn to constantly ask questions while examining radiographs. These questions should always direct your attention to findings that will result in conclusions that have a high predictive value. This keeps your attention focused on those areas that will truly help you pin down a diagnosis. Practicing these steps will yield the most rewarding and most accurate results. The only way to ensure a thorough interpretation is to adopt a systematic approach. A good systematic approach has two major components: a geographic component that ensures that your area of acute vision physically covers all critical areas, and two, a pathophysiological component that includes a mental checklist of possible diseases and their associated radiographic findings that have a high predictive value. For a systematic approach to become a habit, you must always examine radiographs the same way, look at the different structures exactly in the same order, and ask yourself exactly the same questions in the same order. And always remember that our area of acute vision is no bigger than a dime at 60 centimeters, so consciously select your visual area to create the most accurate mental image possible. A good system is to divide the thorax into 4 parts: thoracic wall, pleural space, mediastinum, and lungs. Start with the thoracic wall and look at all structures always in the same order, asking if there is anything abnormal about location, size, shape, and relative opacity of these structures. Look in areas where normal structures cannot normally be seen, but can sometimes be seen if abnormal in size, location, or relative opacity. Work systematically through the thoracic region. Begin with the skin. When examining soft tissue areas, always ask yourself the following questions. Is there soft tissue swelling? Is there subcutaneous emphysema? Are there skin wounds? Are there skin nodules or masses? Are there foreign bodies? Now, ask the same questions when examining the subcutaneous soft tissues. Is there soft tissue swelling? Is there subcutaneous emphysema? Are there skin wounds? Are there skin nodules or masses? Are there foreign bodies? This process is repeated with the thoracic inlet, the cervical esophagus, the cervical trachea, the diaphragm, and lastly, the cranial abdomen. Now you are done with the soft tissue examinations and should proceed with the skeletal structures of the thoracic wall. The ribs. You must force yourself to examine every rib and remember the dime. When examining bony structures, always ask yourself the following questions. Are there fractures? Are there subluxations or luxations? Is there bone lysis? Is there bone proliferation? After the ribs, shift your questions to the sternum, looking at every sternobrae. And lastly, the vertebral column. Look at every dorsal spinous process. Look at every articular facet. Look at every vertebral body. Look at every intervertebral disc space. Look at every intervertebral foramen. And look at every vertebral canal. Though this systematic approach is initially time-consuming, it is the only way to assure a thorough and accurate examination and interpretation of the thoracic wall. The pleural space is the easiest part of the examination. It is a virtual space between the surface of the lungs and the thoracic wall that cannot normally be seen on radiographs. But if there is fluid or air in it, the pleural space will increase in size and displace the surface of the lung away from the thoracic wall. If there is enough fluid or air, it can also become visible between lung lobes within the interlobar fissures. If pleural effusion is present, the opacity of the pleural space will be that of fluid, which is the same as the heart, diaphragm, or liver. If a pneumothorax is present, air opacity will be noted between the thoracic wall and the lungs. In order to simplify this approach with the pleural space, ask yourself 4 questions. Is there retraction of the lung from the thoracic wall and diaphragm? Can I see interlobar fissure lines? If answer number 2 is yes, are they wider than a sheet of paper? If answer number 3 is yes, is it fluid or air opacity? Systematically asking these questions will keep you focused on areas and questions that have a high predictive value for the presence or absence of pleural space abnormalities. Now it is time to look at the mediastinum. Again, look at all the following structures, always in the same order, asking if there is anything abnormal about location, size, shape, and relative opacity. Think about and look for the trachea, the heart, specifically focusing attention on the regions of the heart: left atrium, left ventricle, right ventricle. Next, look at the aorta, the caudal vena cava. As before, look for structures that cannot normally be seen but can sometimes become visible if abnormal in size, location, or relative opacity. The cranial thoracic esophagus, the longus colli muscle, the major cranial thoracic arteries and veins, the mediastinal lymph nodes, the thymus, the cranial vena cava, the retrosternal lymph node, the main pulmonary artery, the tracheobronchial lymph nodes, and finally, the caudal thoracic esophagus. Here again, the anatomy is relatively simple. The only difficulty is in determining what can be seen and what cannot. But if you think in relative radiographic opacities, you should not have too many difficulties. Next, ask yourself the following questions. Is there a widening of the mediastinum? If the answer to this question is yes, is the patient obese? Are the margins parallel or convex? Is there displacement of the trachea? Can I see both sides of the tracheal wall? Beware of the mock line. Is there gas in the esophagus? Are there radioopaque foreign bodies? Is the heart way too big? Is the heart way too small? Remember that subtle changes in heart size do not carry a high predictive value. Therefore, we are only going to concentrate on determining if the heart is way too large or way too small. Is there left atrial enlargement? A lot of people have problems evaluating the lungs on thoracic radiographs. It is partly because few use a systematic evaluation that asks the right questions. As with the previous parts of the thorax, look at all the structures, always in the same order, but instead of asking if there is anything abnormal about location, size, shape, and opacity, ask yourself 5 simple questions that cover just about everything that can be seen about the lungs on radiographs. Those questions are: can I see the blood vessels crisp and clear? Are veins and arteries roughly equal in size and tapered? Do I see air bronchograms? Do I see thickened airway walls? Do I see nodules or masses? Notice that there are only 2 possible answers for every question, yes or no. Of course, there is always the possibility of a maybe, but usually you can lean more toward one or the other, and this is what we should do. Our job is to make these choices. If you are not sure, it's probably normal, but verify with other tests if you can, or consult with a radiologist. If the answers are yes, yes, no, no, and no, the radiographic diagnosis is normal, and you can be confident about it. The only thing you need to memorize is that in the artery-bronchus-vein triad, the artery is dorsal on the lateral view and lateral on the ventral dorsal view. This systematic approach will take some time to learn and incorporate as a habit. Doing it, however, will pay off by increasing your interpretive and diagnostic accuracy. Print out the corresponding handout and checklist as an easy way to remember to ask all the questions and look at all the specific areas of a thoracic radiograph. In the next section, we will explore a systematic approach to interpreting abdominal radiographs.